Um, Ladies and gentlemen, welcome. Thank you very much for your time today here and joining us on the 6th of April for our weekly COVID update with Professor David Wilkinson. So, David, thank you very much for your time, and we'll flick over to you.
Thanks very much, Paul, and good evening to everybody. It's great to have so many people online. What I'm going to do this evening is just share a handful of slides with everybody. I'll put this up on the screen right now, just to give everybody a quick update on what's happening with this epidemic in Australia. And then I've got a slide at the end which has a few hot topics, which are questions, issues that have come through from people over the last few days. And we've got a couple more come through on email as well this evening. And just a reminder to everybody, there is a chat function at the bottom in Zoom at the bottom of your screen. Please feel free to throw questions as we go along. And so I'll just share my screen now. So just to give everybody a sense of the epidemic in Australia at the moment, let me talk you through this slide, which is up to date as of today. The blue bars show you the number of new cases reported across the whole of Australia every day, and the blue line is the cumulative number of those cases. So the blue line is all of the blue bars added up. The most important measure in an epidemic of any type, whether it's malaria or diarrhea or measles or COVID, is the number of new cases that occur each day. And you don't need me to tell you that from early March here, all the way through March, towards the end of March, we had this rapid rise in a number of new, every day seemed to set a record. And then it sort of settled down towards the end of March. And since then, there has been a pretty consistent fall in the number of new cases reported across Australia every day. We should ignore the last day because there's always delays with some states reporting, but a pretty consistent fall in the number of new cases of this epidemic across Australia. Of course, what we're all waiting for now is to see what happens in the next week or two. But this is good news. This is flattening the curve. The blue line here is starting to go flat. This is what we wanted to see in response to the different interventions that the government has put in place. Now, the next slide shows the situation in each of the different states in Australia. And you can see here quite clearly that New South Wales has almost half of all COVID cases in Australia. That's because New South Wales, of course, is the biggest state. It's also because we have had all of the problems, indeed nightmares, with cruise ships coming in. They've all been sent back to sea now, as most of you would know. The other situation with New South Wales is most international travellers fly into Sydney. And so the situation in New South Wales is skewed quite a bit. You can see here Victoria, just over 1,000 cases, Queensland, Western Australia, South Australia, and then Tasmania, NT, very, very small numbers. What's really important here is the dark blue, is those cases that were acquired overseas. They should disappear very soon, of course, because the borders are closed. If you are Australian and you arrive in Australia now, you go into mandatory quarantine. If you're not Australian, you're turned around and sent straight back whence you came. The really important one to look at is this light blue bar here. This is the area that's worrying the authorities at the moment. These are cases that are transmitted locally without a known contact. So the dark blue from overseas, the green color here is locally acquired but from a known contact, and the light blue here is unknown. This is so-called community transmission. It's about 400 in New South Wales, and tiny numbers in all of the other states, right? Really important message here. Tiny numbers in all of the other states. They're very, very low levels of community transmission of COVID in Australia, apart from New South Wales, which is a problem. This is a graph showing New South Wales data only. I'm interested in this because this is where I live and work, but also for the reason I showed on the last slide, which is it's really important to understand what's going on here. The black is the problem. This is the locally acquired cases in New South Wales. Now, there is a little bit of a hint that it's falling here, but we need more days to see whether this is true or not. But the epidemic in Australia now is all about locally acquired cases, and that is essentially the problem in New South Wales. This is a really important one. Paul, of course, interested in this, being stuck in Singapore as he is. This graph shows Australia in the black line here in comparison with a number of other countries around the world. And excuse me, what is important to understand is the scale on the left-hand side, the y-axis, is a log scale. So the gap between each line is a 10-fold increase. It's not a doubling, it's a 10-fold increase. And the key message here for Australia is you can see that the slope of our line has always been a little bit further behind the others, most of the others, and is now starting to turn over. This is the flattening of the curve. And, you know, we have every chance of being a bit like South Korea. Singapore has done incredibly well, but is continuing to kind of go up in a straight line. And they've just recently, over the weekend, introduced restrictions very similar to Australia because they've been having too much community transmission. And Japan is struggling with the same thing. So when you hear the politicians say that we're seeing good early signs in Australia, it's true. And you can also appreciate why they don't want to change anything yet, and they can't afford to change anything yet. We need to see this do that. So enough on the epidemiology. I think the bottom line is to say there are no new cases coming in. Everybody's trying to mop up the locally acquired cases at the moment, and that is a New South Wales problem much more than the other states. There's a few questions have come through, and I've listed some of them here. Let me run through those, and then also the ones that have come through on email, and then very keen to take other questions this evening. First hot topic is face masks. There's been a change in the recommendations in the United States, where the Centers for Disease Control is now in America recommending basically that the public wears face masks when they go out. The Australian authorities are not recommending this. The reason for that is the amount of infection in Australia, in the community, is not high enough to justify the wearing face masks. In our clinics, we're forming the view that we would recommend that all of our staff now do wear face masks when Paul has a shipment coming in very soon. And we think that on balance, it would be worth our doctors, particularly because they're seeing the patients on a regular basis and spending quite a bit of time close up, that it's probably now worth using face masks. The key thing with face masks is you must use them properly. You can't keep taking them on and off. You can't keep fiddling with them. That can make things worse. You're going to wear a face mask, you put it on and you leave it on for as long as you possibly can. Been a question about pregnancy. One of our staff is pregnant. She works on the front desk, as I understand it. I've had a look at all of the evidence from the major Western countries about this. There is no evidence that COVID has adverse effects on pregnancy at this stage, but it's too early to be sure about that, of course. And the advice would be, if you're pregnant, you don't work in a high COVID risk environment like a respiratory clinic. our clinics are quite safe, and certainly for our admin staff, quite safe. Childcare is safe. Childcare facilities are open. Here at the university, we have childcare facilities on campus. They are open as normal. They're staffed as normal. We're all aware the government has spent a lot of money at the moment opening up childcare facilities all across Australia, and childcare is safe. Everybody's asking how long will the restrictions last? My view is for quite some time. The Prime Minister talks about 6 months. The New South Wales Premier talks about 3 months. She also talks about not wanting to put harder restrictions in place, which is reassuring, of course. Easter is coming up, and it's going to be a problem if people start traveling and risk spreading the virus. So it'll be interesting to see, particularly again in New South Wales, because we have so many cases. They just this evening made Airbnb illegal in New South Wales as a way of wanting to stop people traveling. So I think we are going to see these restrictions last for several weeks more. Hopefully, if the numbers fall, then we will see some of the restrictions lifted. So my view is we need to, as we said last week, we need to be thinking from our skin cancer clinics and our general practice clinics that this is a long-term game, and we need to set ourselves up so that, that our businesses are sustainable and functioning in a sustainable way for our patients, a safe and sustainable way for our staff, and a safe and sustainable way for our businesses. With this being the way that that business is done, I cannot see how Australia's borders open up within the next 12 months. I just don't see how it happens. I can see a scenario within maybe, pick a number, 3 months, that Australia itself is safe and functioning, perhaps with social distancing in place, but a bit like Singapore was, with restaurants open, gyms open, but with restrictions on numbers and social distancing in place. You can see that happening in Australia, but I can see that all of this lasting for weeks or a few months, and that speaks to the long-term view that I don't think any of us should be booking overseas holidays anytime soon, because I just don't see how government opens the borders until there is a vaccine or herd immunity or other countries that have this under control. I'll stop there. I have a couple of questions have come through on the email, and then I'm very happy to take questions from colleagues this evening. One of the questions was, what are the risk factors for severity of COVID illness? And the answer to that is mainly age, and secondarily comorbidities, and just about any comorbidity seems to be an additional risk factor. So it's very interesting that we all understand that the rates of infection are pretty equal by age group. So young people are being infected at the same rate as older people, but the severity of the illness is very much driven by age and comorbidity. It is also driven by the dose of the virus. So for example, this is why so many doctors and nurses in Italy have contracted severe COVID illness, because like most infections, there is a dose response curve. If you are close to people who are shedding lots of virus, they have symptoms, they're sick, they're in hospital, then the dose of virus that you get is much higher than, let's say, a casual contact in the shopping center. And there's no doubt that that leads to a much more severe illness. The final thing on illness and severity is it seems that the mechanism behind the severe pneumonia that most of these patients get when they get sick is a so-called cytokine storm. There is an immune reaction that is uncontrolled, and this is what triggers the acute respiratory distress. I've got another question. This one's from Francis Tan, that says, can you tell us something a little bit about asymptomatic infection and the risk of transmission? There's more information coming out on this all the time. The Centers for Disease Control in the United States, which is a very trusted source, has recently published interesting material on this. And it goes a little bit like this. There is no doubt that asymptomatic people and so-called pre-symptomatic people, people who are asymptomatic but become symptomatic, can carry and shed the virus. It's very clear, there's no doubt about that. However, their level of infectiousness is believed to be very low. These are very difficult studies to do, as everybody would appreciate. And so we have to sort of go by the best information people have as the epidemic unfolds. But there is no doubt that people who are asymptomatic or who have symptoms a day or two later can be infectious. And indeed, these are the people who are likely driving the community transmission here in New South Wales. Remember, almost all the other states apart from Victoria have hardly any of this going on. This is very different from SARS. SARS was an illness where if you got it, you were very sick very quickly. And so it was easy to identify cases and their contacts. That's not the case with COVID. There is no doubt that some asymptomatic and pre-symptomatic people are spreading the virus. I think we have some questions. Should I just work through those, Paul?
Yep. I mean, do you want me to? I'm happy to read them if you wish.
Yeah, sure.
If you just want to stop sharing your screen, and I'll get to see your beautiful smiling face. Now, so the first one, David, is just when you're talking around staff should wear face masks, and this has actually come from, once again, a skin cancer practice. Is you mean just the clinical people, as in doctors and nurses, or he's talking about admin staff as well?
Yeah, so I think it's a matter of judgment. I see that's from Monique. Thanks, Monique. I think that we should now recommend that staff who are interacting with our patients should seriously consider wearing face masks when they're available. Again, let me stress, if you're going to wear a mask, you need to wear it properly. You can make it worse by wearing it and fiddling with it all the time. Touching an infected surface and then touching your face and your mask will make it worse. But when the Centers for Disease Control make a recommendation that the American public should be wearing a mask, I think we should be cautious. So I would, if I was a doctor in a skin cancer clinic now, I would wear a mask and I would wear it properly. And I would encourage any nurses I was working with to do the same. I think it's in terms of if you're at the front desk managing patients coming through, I think it's much less important because you've got the distancing and your interactions with the patient is much shorter. But if you want to wear one and feel a bit more comfortable that way, I'd have no objection.
I think the other thing is obviously depending on the clinical environment you're in. I mean, if you're dealing with in a general practice, obviously with patients, might be a little bit different, obviously, than working in a skin cancer practice. But yeah, the point taken. Well, even Donald Trump's not going to wear one, so he doesn't want to listen to the CDC anyway. So the next one is around someone quarantining. So if someone has been quarantined in a Sydney hotel for 14 days, do they have to quarantine again when they travel back to Queensland or to Brisbane, for example? And are they able to go through a drive-through respiratory clinic to be tested on their way home to obviously avoid another 14 days of self-isolation, even though they're probably, technically the government wants everyone to do that generally?
Well, my understanding is that the answer to that is yes. You would need to quarantine again on crossing to another state. I would advise checking, because this stuff is changing every day. For example, I think it was last night at midnight in Western Australia, they closed the border, and nobody, even if you live in Western Australia, is now allowed into Western Australia other than through a very strict exemptions. I know Queensland has moved to a similar situation, and my understanding is they would require self-isolation in the home in Brisbane, but I would check that. I would check that directly.
Excellent. Another question around: should we be leaving BCCs at the moment, not treating, squamous cell or melanoma?
Look, I think, I mean, part of the answer to that, I think, is it depends where the clinic is, right? So, I think if you were in a COVID hotspot, and there are a handful of them now in New South Wales that were designated this morning, and where GPs are being urged to do more testing of almost anybody with is even close to being symptomatic, then you might want to do that. I don't think there's any rationale to cut back on skin cancer services anywhere else in Australia. So most of New South Wales, most of Victoria, and any of the other states, the data are very clear, right? The numbers are tiny now. The number of new cases every day is very small, and there is almost no community transmission outside of a few pockets in New South Wales. So, and on the basis that this is looks like it's getting better every day and going to be with us for quite some time, I'd be saying business as usual. That would be my advice.
Okay, awesome. Question around reading a bit around the symptoms of diarrhea and loss of smell. I mean, should we be adding these to screening questions to patients?
Well, they're both recognised on the WHO list now as symptoms. They're very unusual. I think 3 or 4% is the report on those. So I would be saying we should stick with the main symptoms of upper respiratory infection. A loss of smell seems to be quite specific. It seems to be an unusual one, but if somebody reported it, I think that's relevant. So no harm adding that one. I think diarrhea, probably not. It's just so non-specific, to be honest. Yeah.
Awesome. Well, that comes to the end of the questions that we have here. If everyone's going to think very quickly. But just a reminder that if you do want to submit questions, as I said, we'll be sending out a recording to this to yourself and your peers. You're welcome to lodge any questions in advance via email. Our intention is to run this next week. I suppose, David, I forgot to ask, it is obviously Easter Monday next week, but I think for most of us, we're actually going to be stuck at home anyway. So not like it's going to be a normal long weekend away for everybody. So we'll confirm the time of the meeting next week. So it'll either be on Monday or we'll look to schedule it early in the week next week. But I think for all of us, obviously the message is stay home and business as usual. And I'm sure we probably wouldn't mind an excuse to run away off to our studies and listen a little bit more about where we're at to. And it'll be very interesting to see, as I said, another week's of data, how that's going to bear out. But as I said, we're then going to have potentially the blip the week after if everybody doesn't behave themselves. But hopefully that would be the case. David, can I thank you very much once again for your time? Oops, we got one more question that's just snuck in, but I'll do that. So is there a view that children should be discouraged as attendees accompanying, since there's evidence that may be the main source of asymptomatic carriage and transmission? I suppose as attendees to family, I'm not really sure attendees to what, but.
Yeah, so look, I think it's a good question, Francis. I think you would definitely discourage children coming to the clinic with adults. These days we should be minimizing the interactions as far as we can, in my view. And I think so you know, as we all know, the risk of skin cancer in children is incredibly low. I would still see children if there was a genuine concern from a parent, but I would certainly not have children coming into the clinic accompanying patients. I just think that sends the wrong message. I mean, you know, I think at this time, social distancing is really, really important. And we don't have to be silly about this and go overboard about this. But I think Francis has hit the nail on the head there, and we should certainly not have anybody that's not needed for the consultation in the clinic or the consultation.
Yep, totally agree. Wonderful. So thank you very much, David, for your time, and thank you everybody here who's been in attendance. It's obviously a pleasure to help serve you. Just a quick reminder, on Thursday, we've got a presentation based on insurance. So I think for a lot of us, there's been obviously some media reports around TAL changing descriptors that may or may not be covered, or, you know, due to COVID or other pandemics. So we have a presentation on Thursday around, once again, insurances and the insurances that you may have and the impacts that some of these changes or proposed changes may have. So if you're interested in that, that'll be at 7 o'clock on Thursday Eastern time. Now we're all in the same time zone, so we don't have to give you multiple locations. So it'll be 7 o'clock on Thursday. But look, thanks very much everybody for your time. As I said, please send through any other questions, and we'll look forward to speaking to you next week. Thanks, David. Thanks for your time.
Thanks, Paul. Thanks, everybody.